I'm Tracy Brooks, the pharmacist on the palliative care team here at PRNC. We're developing a set of modules. Today's module is called Approaches to Pain Assessment, and certainly would apply to any kind of patient, not just necessarily a palliative care patient. The objectives of this module are, after watching, you should be able to describe the hierarchy or the order of strategy in assessing pain, and you should be able to explain which tool is best to assess a dementia patient, an ICU patient, and a pediatric patient, and all of these patients are the ones that are unable to self-report their pain. Pain assessment and management are components of the Joint Commission standards of care, and they require every patient to be screened and assessed for pain. All patients with pain, of course, deserve prompt recognition and treatment. Pain should be routinely monitored, assessed, reassessed, and documented clearly to facilitate treatment and communication among healthcare clinicians. The key is doing a comprehensive assessment when you screen and find that pain is there. The effective clinical management of pain ultimately depends on its accurate assessment. So the assessment is the key piece of successfully managing a patient's pain down the road. How can we do a better job? Well, we know that patients deserve to have their pain treated, and the first key component is assessment. So, when you go about assessing pain in a patient, there is a hierarchy or an order that you should gather your information. The gold standard, or the most accurate tool, is asking the patient, or what we call self-reporting pain. In a typical verbally responsive patient, you would ask them to rate their pain on a scale of 0 to 10. That's our numeric pain score. Then, once you found out the intensity of the patient's pain, you would go on to gather further details, like where is the pain and how bad is it? Describe the pain, what makes it better or worse, and etc. The patient's self-report is the most accurate and reliable evidence of the existence of pain and its intensity. This holds true for patients of all ages, regardless of communication or cognitive deficits. Even if a patient can't communicate or can't concentrate on the pain intensity scale, go ahead and ask your patient the simple question about whether or not they have pain. A yes or no answer, indicated by nodding, head shaking, or other signs, should be considered a valid self-report of pain. If at all possible, ask the patient. Even intubated or sedated or demented patients, ask them to self-report. As you can see, the numeric pain scale is validated for adults and children 12 years of age and older. So, now you've got patients that are unable to self-report. Those patients have altered levels of consciousness, sedated, maybe they're on mechanical ventilators, they're demented, and certainly our younger pediatric patients are unable to self-report pain. So we have to take other measures to detect and evaluate our pain interventions. No single objective assessment strategy, such as a behavioral tool, looking at the pathology or causes of pain, or estimates of pain by others, is sufficient all by itself. So, we need to combine our methods to evaluate and assess this type of patient's pain. Like I said, no single objective assessment strategy is sufficient by itself. I tell people it's sort of like putting together a puzzle, and we have to gather pieces of the puzzle before we can see the picture. Okay, so in patients that can self-report, that's the gold standard. We ask them to rate their pain score. Now, the first thing I do in patients that can't self-report is I search the medical record for potential causes of pain. Did they come in with any pain-inducing pathology, such as a fractured femur or a fractured hip? Do they have a history of diabetic neuropathy in their lower extremities? Do they have a raging infection right now? Do they have progression of disease, such as breast cancer going to the bone? These are all pathological causes of pain that I would determine and use as one piece of my evidence. Then I go ahead and look, are we doing any common procedures that would be likely to cause pain? Even routine care, such as sectioning and turning the patient, can be extremely painful. Procedures certainly can be painful. Invasive instrumentation, needle sticks, chest tube removal, etc. And wound care certainly can be very painful for patients to suffer through. Now, after I look at the chart and look at what procedures we're doing as potential causes of pain, I also observe the patient's behaviors using a behavioral tool to see if there's any signs of discomfort or pain. Here's an example of a behavioral tool. It's sort of like giving a patient a test. You ask them questions or you grade them on the different questions by giving them a score. So you can see on this particular behavioral tool, we're looking at facial expression, body movements, and muscle tension, and we're giving them a score and evaluating how their total score rates. In this particular tool, the pain range is from 0 to 8. So if the patient scored an 8, that's some pretty good evidence that they are having some significant discomfort. Plus, using this tool, we can use it to screen for pain, but we can also use it to help evaluate and assess whether our intervention was successful or not. So behavioral tools are very important because there are standard criteria that we use to evaluate the patient. And these tools also promote consistency among healthcare providers. So the first shift, second shift, and third shift nurses, if they're all using the same behavioral tool to assess the patient's pain, they're getting a very consistent way to assess their pain throughout the day. In Epic, we have pre-built pain behavioral tools for you to do your documentation. And you can see I have them divided under tools that we use for the adult patient and tools that we use for the infant and child patients. And you'll notice that I have the Wong-Baker-Facey scale highlighted in red. Let's talk about the Wong-Baker-Facey scale real quick. Everybody is familiar with the different pictures of the faces. This tool is validated in children greater than 3 years of age. And it's been validated in older children as well, up to age 17. The proper use of this tool is that you explain each face is for a person who has no pain, some pain, or a lot of pain. After explaining the faces, you then ask your patients to choose the face that best depicts the pain they are experiencing. So as you can see, this scale is not valid in patients that are unresponsive or on a ventilator. It's valid in patients that can self-report or pick the face that best depicts the pain they're experiencing. Now, it is appropriate in certain cases to use this scale in the older adult population. I find it helpful in patients with perhaps a limited education or a low health literacy rate, or even in dyslexic patients, the ones that are having trouble with the 0 to 10 scale. Sometimes I use this scale, explain it to them, and have the patient pick the face that best matches how they're feeling. And not just to drive home the point, but on the Wong-Baker-Facey's webpage, they have posted this official question that was asked of them and their scale. We have patients who are unresponsive due to their injury, illness, or medications. Is it possible to use the Wong-Baker-Facey's pain rating scale by comparing the patient's face to the faces on the scale? Their reply is the Wong-Baker-Facey's pain rating scale is a self-assessment tool. The patient must be able to understand the tool and be able to indicate which face most closely depicts the pain experience. This is not the tool to use for unresponsive patients. Okay, so the key to using behavioral tools is, first, you need to pick the appropriate tool designed and validated for your patient. The fact that the Wong-Baker-Facey scale is not accurate in non-responsive patients illustrates the point on this slide. If you pick a scale that is not validated for your particular patient, the results you get are pretty much meaningless. You don't know whether they're real or right. The second thing to keep in mind when using tools is you need to acquire proper training on how exactly to use that particular tool. Again, giving the example of the Wong-Baker-Facey scale, that is not a scale where you match the face to what the patient looks like. It is a self-reporting scale, so it's very important that you know exactly how the scale is designed to be used. So in a perfect world, you pick the right tool, and then based on the results that you get, an action plan is put into action. And then at a reasonable time later, you use that same tool and reassess your patient to see if the intervention was successful or not in relieving the pain. And then based on the new score, you determine if readjustment is needed. You can see how the consistent same tool is used to screen and to evaluate the intervention that you're trying. Okay, so moving on to other ways to evaluate pain in patients that are nonverbal. Certainly, you can do what's called surrogate reporting. This is where you obtain credible information from a parent or another person that knows the patient well. This is called proxy or surrogate pain reporting. Parents and caregivers should be encouraged to actively participate in the assessment of their loved ones. Always listen to what family members and caregivers say. This is part of your gathering information piece. Encourage their comments. This builds trust between you, the clinician, and the patient. However, we all need to keep in mind that family and caregiver feedback is often emotional, which may or may not be entirely factual information. So family members do tend to overestimate pain intensity when compared with patients' self-reports. But again, it's just one piece of the puzzle that you're gathering information. And then finally, another piece of the puzzle that I occasionally use is if you really can't determine whether or not the patient's symptoms are caused by pain, I will initiate an analgesic trial, either using a non-opioid or a very low-dose opioid, if I suspect pain might be causing the behaviors. If I get an improvement on the behavioral scale after I initiate the analgesic, that's a good sign to me that perhaps pain was part of the behavioral issue, and I'll continue using that analgesic. Okay, just as I showed before, in EPIC, there are different ways you can document pain. Here are your choices. For the adult and for the infant, you can chart no pain. You also have choices in the adult, the 0 to 10 numeric scale, the advanced dementia scale, and you have a choice where you can put unable to assess. For children, there's the FLAC scale, the NIPS scale, the INPAS scale, the Wong-Baker-Facey scale, which I said could be used in adults that can self-report, and unable to assess. Let's look at each one of these behavioral tools. We already talked about the numeric rating scale. It is clearly the most accurate data for assessing pain intensity from the patient. For patients that are able to provide you with verbal responses, the alternative behavioral tools we're going to talk about should not be considered as a routine substitute for this numeric rating scale. If the patient can verbally answer your questions, definitely go with the numeric rating scale. And you can see that mild is 1 to 3, moderate is typically 4 to 6, and severe is 7, all the way up to 10. And again, who is this scale not useful for? Confused patients, patients unable to express themselves, unresponsive patients, and certainly the younger pediatric patients. Okay, in adult patients that are nonverbal, not able to self-report their pain intensity, we have in EPIC the Pain Assessment in Advanced Dementia Scale. This scale was developed and validated originally back in 2003 in institutionalized patients whose dementia was so advanced that they could not verbally communicate the fact that they were in pain. You can see that there's 5 different behaviors that are graded on a scale of 0 to 2. Then the score is added together and you get a score of 0, somewhere between 0 and 10. This scale has also been found to be reliable and valid in hospitalized post-orthopedic surgery older patients that are cognitively intact. That was in 2008. And more recently, in 2011, one study validated it in nonverbal ICU patients. So this is the tool for now in EPIC that you would document and use to assess your nonverbal ICU patients. Now for the pediatric side, we have the FLAC scale, named because of the face, legs, activity, cry, and consolability categories that you are going to rate these children on. It's been validated in infants 2 months all the way up to children of 7 years, and it's the same idea as the pain AV scale. You rate them, you circle their scoring, and you add it all together to get a total score between 0 and 10. Next, we have the Neonatal Infant Pain Scale, or NIPS. This is a behavioral scale which can be used for either full-term or preterm infants from birth to 1 year of age. Again, you score each indicator based on your observation of the infant for at least a full minute. Then, based on the score, you see where their pain level is. Now, this scale is a little bit different. The highest score you can get on this scale is a 7. So this is a 0 to 7 scale. And then finally, looking at the INCAS scale, this is a valid and reliable tool for assessing pain and agitation and sedation in ventilated and or post-op infants 0 to 100 days of age, all the way down to 23 weeks gestation and above. It was especially designed to assess prolonged pain, agitation, and sedation in the neonatal population. Now, as I mentioned, there are 2 other options besides the behavioral tools for documentation in EPIC. One, you can document no pain in your patient, and certainly that is very acceptable. There are a lot of patients that their hospital admission has nothing to do with pain. They will need to be assessed far less frequently than patients that do have pain issues. Now, the other option in EPIC is to chart that you're unable to assess their pain. And really, in my mind, since we have these tools that are validated in patients that can't respond to your pain questions, this is really not an acceptable documentation in most circumstances. So let's try to avoid this most of the time. Now, I know chronic pain patients can be very difficult to assess. There are some that will constantly rate their pain 10 out of 10 for their entire hospital stay, no matter what medications and non-medications you try to treat their pain. This particular pain scale, the functional pain scale, is not available in EPIC, but you can still use this in your documentation like I do. When I have a patient that consistently and continually rates their pain 10 out of 10, no matter what I am doing for them, I go about assessing their pain a little different. I reach for this tool and I focus on asking them questions about their functionality. Are they able today to watch TV? Are they able to talk to guests? Are they able to use their iPad or their cell phone? Or are they able to answer the bedside phone? Are they able to walk to the bathroom, etc.? And often what I do is observe the patient without them knowing for 5 minutes before I go into the room, make this kind of documentation. Then I go in and use the 0 to 10 scale and get their self-reported intensity, but then I ask them questions and see if their answers change while I'm asking them compared to when I was observing them. Okay, the conclusion of our talk. First of all, as we all know, all patients need to be screened for pain at admission. This is a Joint Commission standard. It is crucial to pick the correct tool to get meaningful data for the medical team to further treat the patient appropriately. Unable to assess is really not an acceptable means of documentation in most circumstances. We do have the tools that you can use in patients that are unable to self-report. Certainly, the frequency of assessment and reassessment depends on the treatment plan and the situation. And difficult patients certainly require more time, more energy, and more documentation. I hope this has been helpful to you and will better help you to assess pain in your patients. And stay tuned for our next module. Thanks a lot for your attention.